Hello, welcome to the AEMT lecture series. Welcome back. This will be video number 1, chapter number 36, Pediatric Emergencies. So, 1 second here. Bam. All right. Glad to have you guys back. So, we're going to talk about pediatric emergencies today. How we're going to treat them, what to look for, and how do we assess. And so let's jump right into it. So 20,000 deaths per year, pediatric deaths per year, and this can be attributed to motor vehicle collisions, burns, suicides, and homicides. It's definitely a high stress environment to be in because we have more than one patient. We have two patients. We have the pediatric patient who's in need of care. And then, of course, we have the guardian or parent who is in, freak out mode. So, yeah, it's stressful. Lots of people love the kid that are there. The parent can feel guilty, and the parent can feel exhausted from maybe the patient's chronically sick, and this has been going on for some time. So it can be a bad situation all around. So you could be frightened. You may show too much empathy, may not show enough. It just kind of depends, and it depends on if you're ready for this call. Do you have the background knowledge available to you to problem solve and critically think during a pediatric emergency? And the only way you can prepare is to study and to be ready to act within your scope of practice to make a difference. That will help the frightened. That will help the professionalism come a long ways. It will help the scene all around. Who has control of the situation? And that's number one job that we have to do as soon as we get there. As soon as we get there, we have to let the parents know that we have this. We've trained for this. We're prepared for this. And we can handle the situation. Now, that the parent is going to be sizing you up from the time you get out of the ambulance or fire truck. From the time you walk up to the door, you're being sized up from what they've seen on television. Possibly they may have a friend that's a professional firefighter, AEMT, professional firefighter paramedic, who has made an impact in their life. That's what they're going to judge you by. And so I think everyone expects a certain level of communication, a certain level of language that is going to be shared, and I think that's what's expected. And the minute you show weakness in that, you lose control of the situation. What are the patient's needs? Well, we're talking about a pediatric patient here, and so there's lots of fear. There's fear you're going to hurt them or hurt them more than they're already hurting. They do not want to be separated from their loved one. They're thinking that they're never going to see them again. You're going to take them away because they have an imagination. Their imagination runs wild. I mean, they think monsters are still under the bed. And so it's important to understand that fear is there, and the way that you overcome the fear, and you're never really going to completely overcome their fear, but you have to let them know that you're different. You have to get on their level. You have to make eye to eye contact with them, and you can't tower them. But you can't lie to them either. You have to tell them the truth. And I start off by introducing myself at their level. And I tell them right off the bat, I'm not going to do anything to you to hurt you unless I tell you first. I let them know. I'm going to tell them everything that's going to happen before it happens. And then you'll start building a trust. And there'll be a bond that will eventually be built there, depending on what you have to do, depending on the needs of that patient. Be honest. Like I just said, be honest. You want to include the care and those decisions with the parents. Let them know. Okay, look, really quick. Looks like your son, daughter is having an asthma attack. We're going to start them on a breathing treatment. It's albuterol. And that's going to open their lungs up. It's a smooth muscle dilator. It's a bronchial dilator. It's going to open those lungs up, and hopefully we'll see some improvement within a couple of minutes. Okay, let them know while you're mixing albuterol and Atrovent up that this is what we're doing. This is what we think is causing the problem, and this is how we intend to fix it. Try not to use medical terms. Like I said, smooth muscle dilator, vasodilator. They're not gonna. But if you catch yourself doing that, if you say it's a vasodilator, I always try to come back with which means that the bronchioles in the lungs are really tight right now. It's going to cause them to get bigger. Okay, it's going to let more air get through. It's going to cause them to get larger. It's going to allow air to move through. That wheezing noise they're making that because they're very tight. So hopefully we'll be able to make that airway or those bronchioles in their lungs bigger. I try to always explain it to them, to anybody that way. One, it lets them know you know what you're doing. That not only can you have the medical verbiage, but you can explain the verbiage. It only takes a few seconds. And yeah, I think we've covered that slide for the most part. All right, basic points. Okay, so oxygenation, is it adequate? Okay, and what about CNS function? Is it adequate? Cardiac output, okay, is it adequate? Oxygenation, ventilation, cardiac output, is it all going to crash on me before reaching the hospital? And so I have a patient, let's say I have a patient here who's having an asthma attack, and it's moderate. Maybe it's moderate to severe. Maybe you're knocking on respiratory failure's door. All right, so I don't need to start bagging this patient now, right? But it's in the back of my mind that I might be bagging them in the ambulance. I might be bagging them just before we get to the hospital. So those are the types of decisions. Those are the types of forethought that you need to have when dealing with with a critically sick pediatric patient. Do I need C-spine? Okay, is this a trauma? Is it fall related? Do I have an altered mental status? We just don't know. Am I dealing with more than one system? Do I have respiratory distress and major fractures? That's what we're going to try to come up with. If I'm going to do something invasive, I do try to outweigh the risk and consequences. All right, do I have time to do this? Is this something I need to be doing en route to the hospital? But sometimes the risks are adequate. They meet the needs of the patient, and so they do sometimes the treatment provided outweighs the risk. Is the parent coming with the child, or is the parent having to deal with 8 other kids? How are we dealing with this? All right. So if they're not coming, do we have an adequate history? And please, do we know the whole story? So when did this happen? Right? When did this start? How did it start? What did it start with? How did the patient present 2 days ago? Did we have fever, etc.? get your whole story straight. This may mean that your partner or somebody else is loading the patient while you're talking one-on-one with the guardian, and the ambulance or the bus is not leaving until you get there. And so they're in the truck, great. We're going to let them take the lead on patient care until you get back. Let's get a full story. Let's get all the questions we can answered so that when we get to the hospital and we're asking, well, is this the patient's normal mental status? Then we have an answer for that. We go, yes, it is, because I asked, and this is what they said. And then, if it's load and go, then we need to load and go. However, I'm telling you that 2 minutes of getting the story straight is essential. It's essential. So you need to do that. And of course, reassess, and if you didn't think about it, reassess. So yeah, the priorities of patient assessment are similar to an adult. They're similar to the checkoff sheets that we do for adults. But there's a little bit of difference because usually a pediatric problem is a respiratory problem. It just always is. If you resolve the respiratory part of it, then everything else seems to get better. All right, let's talk about this Pediatric Triangle. Okay, and so the way we assess a patient is different on pediatric, meaning we can't just walk up and start getting our questions answered when we're dealing with a Sorry, stand by 1 second. We can't always get our questions answered when we walk right up to a pediatric patient, right? So there's some differences. So one, appearance. Oh, the whole slide's not on there, is it? Hang on 1 second, let me fix that. All right, now we got, still kind of shows off the screen, but okay. Let me see if I can fix it one more time here. Well, I'll talk you through it. All right, so the pediatric triangle we're looking for is A is for appearance. Okay, and so what does is the patient responding appropriately for age? Okay, and what about the body position? Is that normal? And tone of the patient. Then we're looking for breathing. Okay, so we're looking for visible movement and effort. And so I want to know chest rise and fall. Is it appropriate? And then we're looking for circulation. And we're going to look at circulation with color. Okay, what's the patient pale, cyanotic, flushed, etc. And so if you're not very good at being observant, you're going to have to get good at it on pediatrics because sometimes it's all we have to go on. You'll walk in the door, and I can't tell you how many times parents have tried to hand me their kids, and before I've even introduced myself, I'm like, no, I don't want it right. I don't want your baby right this second, unless that baby's blue. But because as soon as I get the patient, what's going to happen? Yeah, patient's going to start crying. And so how can I assess a crying patient? I can't assess it good. At least I know if they're crying, the airway's open. But I need, I want to be able to observe that patient and its interaction with the parents. I want to observe the chest rise and fall. I'd like to look for accessory muscle use, trachea tugging, nasal flaring. All of that is part of a good general impression, primary assessment of your pediatric patient. You can't do that so well when you're holding them and they're crying. So I usually like to tell the parents, hold on to them just for, a minute or two. Okay, got the slide back up here. Okay, look. So again, appearance, and so how we're going to look at appearance and mental status. So we're going to use AVPU, right? Alert, verbal, pain, or unconscious, and we use that age appropriately, right? You know, if it's a 2-year-old is going to be alert differently than a 1-year-old, right? And then breathing. I'm looking at that airway and I need to determine if it's open. Is there respiratory effort present? Are there sounds that I need to be aware of? Grunting, right? Stridorous sounds. What's the rate? All right. I want to know. I don't want to know at this point. It's 34, breaths per minute. Is it fast or slow? Okay. Is this kid really working to breathe? Or is this, or are we okay? And then central color. I want to know, is this pediatric patient pale, mottled, gray? Does this patient appear to be perfusing? And if not, then I can start trying to figure out why. And then circulation. I would like to know pulses. Are they fast? Are they strong? Are they fast? Are they slow? Are they strong? Are they weak? The skin temp and color. I'd like to know about capillary refill. Okay, and we use that. We don't use blood pressures really in children under 3 years of age. I don't need a blood pressure on a patient 3 years and younger. I want to know circulation status, but not a blood pressure. All right. Let me move myself right over here. Now then, all right, there we go. All right, so initial assessment, categorized. Okay, is this a stable patient? Is it, I like to say sick or not sick. Okay, if we're sick, let's go to work. If they're not sick, let's find out some more about what's going on. Is this a potential patient? Is there potential for failure? All right, or is this a definite patient? But really, I think sick or not sick really answers the question quite well. Is this patient sick or not sick? If they're sick, what do we need to do to fix it? If they're not sick, let's find out some more info. As part of your initial assessment is to correct any life-threatening presentations. Okay, so airway occlusion, patient's airway needs to be suctioned, that sort of thing. If it's not correctable, do we need to support it some way? Right? Do we need to think about providing oxygen? Non-rebreather maybe, or something like that. Blow by, right? And then we need to think about transport. And maybe we don't go to Rockdale. Maybe we go to an appropriate facility for the patient, such as Eggleston or Children's Hospital. Vital signs. All right, so really, you know what? As part of my secondary survey, I could get a pulse rate off the pulse ox. I'm good with that. Depending on the patient's age, I can use a blood pressure. But really what I'm thinking about is in kids, they don't like pulse oxes. They'll shake it off in a heartbeat unless it's a really good commercial pulse ox that tapes on and that fits. There's not many pre-hospital care providers that provide it. So that's just part of it, right? So if you don't have the proper equipment there, it makes it essential to look at that patient's color, chest rise and fall, accessory muscle use, nasal flaring, tracheal tugging. All of those become extremely important now. And that's how we're going to decide whether we're going to treat this patient with oxygen or is this a respiratory failure patient that we're going to bag. Heart rate, some things that can cause heart rate to be high, of course, is fear, pain. A big one's fever. let's say you're feeling a brachial pulse. So let's say you put the patient on the monitor and you just haven't touched your patient yet. I hope you've observed them, but maybe you haven't touched them yet. Shame on you. But okay, maybe you haven't. I'm not saying I haven't ever done it before, but let's say you look at the monitor, the patient is 11 years old, has a heart rate of 138. Well, that's fast for an 11-year-old. So one thing I'm going to think of is fever. Fever makes heart rate go up, and does that match the mental status of the patient? Is the patient very sleepy, kind of altered? Not really altered, answers questions appropriately, but just wants to kind of drift back into zoning out or sleeping and that sort of thing. Remember that heart rate is going to go up before your BP falls. Blood pressure in children, when their BP decides to fall, it's usually decompensated. Children compensate very well till they begin to decompensate. Bradycardic patients, okay, patient less than 60, infant less than 80, okay, you're thinking now, is there a respiratory problem? Is my patient hypoxic? Is my secondary to asthma, or my hypoxic secondary to airway obstruction? But usually children who are bradycardic are hypoxic. They can be a patient who has epilepsy, who sees on and off, and maybe this is that 5th seizure of the day. Parents have been treating the patient at home, and it's not working. Well, as they get older, people seem to start getting used to used to seeing a seizure, and it's more normal when they see it, especially teenagers who observe another teenager seizing. And what happens is they can have 3 or 4 seizures before mom and dad get home. And then maybe these were really bad seizures today, and maybe now you get there and they're hypoxic secondary to so many seizures, like a status seizure, right? They never really come out of the seizure. Maybe somebody thought they did, but they really haven't. And I've seen some kids, I've had one that died that I had that was like this. They presented in a they were seizing. I treated the seizure, and no big deal, nothing was wrong. We get to the truck, and the patient starts becoming bradycardic. And so I knew, just like today, I would treat it no different. I was working with another paramedic from the private ambulance service who was excellent that day. I was working on the fire truck. I gave the patient drugs out of our drug box to control the seizure. Patient gets in the back of the AMR, I already said it, gets there. We load the patient up, and I told the medic, I was like, I'll try it with you. I had to get signatures for the narcotics. Anyway, we get in the back of the truck, and the patient starts bradying down. Patient had a initial pulse rate, of course it was high because of the seizure. After the seizure, it was in the 90s, and we bradyed down from 70, 60s, 50s. Now, when we were in the 50s, I was bagging the patient, even though the patient was breathing a little bit slower and had adequate tidal volume and had a decent end-tidal CO2 at the time. My training's always taught me a patient bradycardic, it's respiratory until proven otherwise. Well, at the end of the day, the patient had been very hypoxic and secondary to status seizures throughout the day. I didn't have that information from when I was on scene. All right, so hypoxia and bradycardia. So you can use this if you want to. Children's greater than 1 year old. It's systolic blood pressure times their age times 2 plus 80. But either way, you got to know these. They're in your book. You have to know what normal blood pressures are for all the age groups, because if you don't, you're going to miss a bunch of questions. I've already talked about hypotension and it being a sign of decompensated shock. The book says that you need to, because children's respiratory rates can be a little bit erratic, so they would like you to take a full minute to count the respirations. And so approximate upper limit of normal around 40 minus the age in years. Yeah, greater than 60 respirations per minute and you're looking at failure. A good way to get this information is from the end-tidal CO2, because it will tell you the breaths per minute, and so you can look at that and tell. But yeah, if you're approaching 60, it's time to start thinking that maybe we're looking at something that looks like failure. All right, so we're going to check the thumb and heel in pediatric patients because their nail beds aren't really there yet. And for less than 2 seconds, yeah, it's going to be a normal reading. Anything that's greater than 2 seconds will be abnormal. Remember, cold weather is going to make your capillaries shrink, and so you won't get an accurate reading. All right. 98.6 is a normal temp. That's 37 degrees Celsius. We're not adding a temp, or some people used to say you would add a degree to your temperature readings for axillary stuff. We don't. It's whatever you get is what it is. Normal 97.6, and I would say it's 98.6, but we'll go with the book. Remember, children under school age, we're going to do a toe-to-head assessment because they don't like you in their face. They start getting nervous. So, quick toe-to-head there. You know, avoid hypothermia as much as possible. Remember this question because it'll be important to you later. Fontanelles usually remain open until 12 to 18 months. If the fontanelle if it's sinking, it usually means that the patient's volume depleted. If it's bulging, like palpating, I think that's the appropriate term now. Bulging probably is the appropriate term here. Anyway, if it seems like that, then you may have an increase in intracranial pressure. And if if you discover that, maybe a clear sign the patient has a head injury. Maybe it'll help to make sense of your call. So definitely when we're looking at the chest, we're going to be listening for breath sounds. Yeah, and silence. We like to hear kids, cry. We like for children to be aggravated. Okay, that lets us know a lot that's going on. Okay, history. Yeah, good luck, but no. You probably, of course, depending on child's age, you won't get it from them, but you may, if they're 12, 13, 14 years old, you may get some information. Your best source hopefully going to be the parents or guardians. But 5-6-year-old kids can tell you a lot. So you might want to listen. Might want to listen to that. And of course, parents will fill in the gaps. Remember, sample. Okay, allergies, medications. Sample. No need to repeat that. I think it's so important to make a good, evaluation of your scene, because just take a minute. It doesn't have to be a pediatric patient call. Just take 15 seconds just to scan your environment. See what you see. Do you see anything different? You're not being judgmental, but you may see something that means something later. Okay? So guys, we've been going 30 minutes on this. I'm going to finish this up with a second video so can keep you guys lively. We will do video number 2 shortly.